Good evening, everyone. And tonight we are here together with the Cancer Working Group members to introduce our new challenge in cancer physiotherapy. Recently, some challenge trial have changed the way we see physiotherapy in cancer care. And tonight we want to share these results. With our cancer working group, we are really trying to having an impact. So tonight we will share with you what this impact is about. So tonight, the three members of the working group, Nirit Rotem and Dr. Nele Adriaenssens and Dr. Grainne Sheill, will present you the challenge trial. Nirit will go through the presentation of the studies. Nele will explain you the study and especially the results of the challenge trial. And at the end, Grainne will specify the clinical implication of these studies. Before we go in the challenge trial, I just want to enlighten with you the impact that the Cancer Working Group of the European Region for Physiotherapy is having. We starting by publishing an important paper on the role of physiotherapy in cancer care in Europe. Recently, on the 5th of November, a document with the European Cancer Organization was published where our Cancer Working Group was able to write down about physiotherapy in cancer care, and we are working for future for entry-level competencies in cancer physiotherapy. And before I give the floor to Nirit, I want to just show you this box that you will find in the document Next Level EU Cancer Survivorship and Quality of Life Policy that you can find on the website of European Cancer Organization, where it's stressed how physiotherapy is important in cancer care. You know, we stress the importance of physiotherapy in the functional assessment and rehabilitation plan made by physiotherapists. We stressed also that physiotherapists have to be core members of oncology care teams and that physiotherapy have to be universally accepted. People have to be in physiotherapy with an easy clinical path. And also, as we are doing for the entry-level competencies, we are starting to ask Europe to focus on giving more substance to the education in entry level in cancer physiotherapy. So that's what we are doing right now. It is a lot, and we keep on doing that. Our working group is very proud. As tonight you will see that each member that will speak is a proud member of the working group. So I will leave the floor to Nirit to enter this beautiful word of the challenge trial.
Why are we here and why are we doing so much work on behalf of the working group on cancer, physiotherapy in cancer? Cancer, there are more cancer patients each year in Europe, more than 4.5 million people, new cancer cases per year. That is more than stroke patients, which we know and regularly see, and even more than MIs, heart attacks. So cancer is, there are many patients out there who would enjoy having physiotherapy. We already know for quite a while now, and based on good research, that physical activity, exercise, physiotherapy affects sleep quality during cancer treatment and survivorship, helps mitigate related adverse events, especially fatigue, which is the major side effect of treatments, improves psychosocial outcomes, improves physical function, has positive effects on immunity, and of course has a positive effect on quality of life. So that is known for quite a while. We already know a few other things, but we didn't have the ultimate studies yet research. So we know that exercise may decrease the recurrence risk for cancer patients. We've known that for a while, but we were always confronted with the problem of the ultimate studies. Physical activity lowers the risk of cancer-specific mortality. And physical activity, exercise, lowers all-cause mortality of cancer patients and survivors. So we knew that for a while. We did not have the best evidence available. And then came the challenge trial. And it actually got a lot of attention, both in the medical world, and it was published everywhere. It was the highlight of the annual oncology conference in the States, and it even got to the popular news outlets, and was talked about and got a lot of attention. So it is a game changer because now we have a third phase RCT published in probably the most prestigious journal, which states and shows that exercise is medicine in cancer patients, in cancer care. It is a large and complicated study, so we'll go through it to make it understandable, and then Nele will do that for us, and then Grainne will explain to us or highlight the clinical implications and how we can take the results of this study forward and to improve our care, cancer care, wherever we work.
As Nirit was explaining, I will guide you through this important but maybe a little complex study, but we will keep it easy, so no worries, and I will guide you through it. So the name of the trial is Challenge, and actually Challenge, it stands for Colon Health and Lifelong Exercise Change. It's a study that already started a long while ago, so it's good that we finally have the first results on it. I hope you can see my slides, and I hope they are moving along with as I'm speaking. So first of all, I want to present to you the methodology. I won't make it too boring, don't worry. We will go through it together, the results, and then of course the discussion and conclusion. But I think the most important thing will be at the end if we can have your questions and we can make an interactive discussion about this. I also want to acknowledge the NPI, which is an institute from the Netherlands, because they were actually the first to introduce a webinar on this article, on this publication, and it was last month. So we thought it was a good idea to even spread the word even broader. And so that's why we are organizing this evening for you. So this is the study protocol. As we were already saying, it's about patients who had surgery for colon cancer. It's a stage 3 or high risk stage 2 cancer patients. And they also had chemotherapy within 2 or 6 months. So it means that after they finished the chemotherapy, they were included in the study after 2 to maximum 6 months. They also had an ECOG score, which is the performance status. So it means that the patients had no physical disabilities. So in a stage 0, which was the majority of the patients. And they had less than 150 minutes per week of moderate to vigorous physical activity. And this means that's what they expect the World Health Organization from every one of us. It's what we should do to stay physically healthy throughout our life. And they also had to be able to walk at a causal space of 6 minutes, so which is average. Then after inclusion, they did baseline testing. And what did they test? You can see it at the end, the primary and the secondary endpoints. So, but first they were randomized in two different groups. There was an intervention group and a control group. And the control group, they only received health education materials. So they were advised to have a healthy and physically active lifestyle. And the other group, the intervention group, they had the same instructions together with a structured exercise program, which we call SEP in the next slides. And the intervention, it took 3 years, but it was in different phases, as I will explain in the next slide. The primary endpoint where they focused on and for which they made the sample size calculations and the power of the study was the disease-free survival. So this is the main outcome. And the secondary endpoints that we will focus on today, we unfortunately, for the matter of time, we cannot go into depth for all of them, but we will focus on overall survival, patient-reported outcomes, physical fitness, and exercise adherence. Those are the most important ones for us as a physiotherapist for now. So this is actually the intervention. And as you can see, the intervention had two main parts. They had behavioral support sessions and supervised physical activity sessions. And the first phase of the 3 years was between 0 and 6 months. So the first half year was phase 1. And then they had to do 12 mandatory behavioral support sessions. They were in person bi-weekly, together with the supervised physical activity, which were 12 mandatory sessions plus 12 strongly recommended physical activity sessions. And then the next half year, it was the second phase. They had 12 mandatory behavioral support sessions, which were in person or remotely. And again, it was bi-weekly. But then for the supervised physical activity, had 12 strongly recommended sessions. And in the last phase, these were the last 2 years of the 3 years, they had 24 mandatory behavioral support sessions, which were again in person or remotely. And then they had it once a month. And for the supervised physical activity sessions, they had 24 strongly recommended sessions. Here you can see for the educational materials, they gave them leaflets on healthy eating, for example, and to stay physically active. But for the group of the structured exercise program, they also designed, so the group of this consortium, they developed already in 2010 a specific guideline for exercise in colon cancer patients. And that's the one they used during this trial. What was the amount of activity that they had to do during this structured exercise or physical activity? They had a baseline of already about 10 met hours per week. And so what they tried to do, or the physical activity goal, was to have an extra to increase the recreational aerobic exercise from baseline by at least 10 met hours per week during the first phase, so in the first 6 months, and then to maintain or even further increase this amount during the final 2.5 years. So they looked at phase 1 to improve or to increase the upper limit to maximum 20 in phase 2. And depending on the phase 2, how much activity they had, they even increased it with an upper limit of 27 met hours per week for phase 3. So it was an individualized or personalized prescription. For the ones that are not really familiar with this metabolic equivalent, it's a standard unit that estimates the amount of energy the body uses during a task compared to the rest activity. And you can see an example at the slide. So they were doing during the week their normal activity level, but then depending on the amount and the load of activity that you're doing and the amount of time that you're doing it, they calculate it in met hours per week. And so this met hours per week, they wanted to increase it throughout the intervention. But Grainne, in the next slides, she will tell you more about this as well. So for the results, maybe the most important one, this is a very chaotic slide, but actually I can explain it very easily to you. So they had 889 patients that were recruited between May 2009 and January 2024. And so they randomized them in two different groups. The intervention group, which had 445 patients, and the other group, the control group, who had 444 patients. If you want a detailed description, you can see it in the left side of the slide, because of course there are dropouts during those kind of long-term interventions. But so to keep it simple, we had 445 and 444. About this whole group of 889 patients, they were recruited at 55 different centers around the world, but more than 94% were recruited in centers in Canada and in Australia. So the demographic spreading was not that big, but in general, the patients also came from France, from the United Kingdom, Israel, and the United States of America. If we look at the total group again, and we look at the baseline characteristics of the patients, we see that there was a gender balance. 51% were women. The mean age was 61 years old. 38% of the patients were obese. And as I was explaining earlier, 73% had an ECOG or performance score of 0, so no physical disabilities whatsoever. At the right side, you can see the medical characteristics. So 90% of the patients was in a stage 3, so the most severe stage that was included. And 76% of the patients had chemotherapy, FOLFOX or CAPOX. Those are the two most common chemotherapy, the drugs that are used for these kind of cancers. So this means that there were no meaningful differences between the two groups at baseline. And so it means that they are two homogeneous groups. So these groups can be compared from the start. And so we can follow them over the 3 years and can compare them. First, if we look at the adherence rate, you can see here, this is only for the intervention group, so the SEP group, and we divided them in the behavioral support, which is the dark blue bar, and then you can also see the gray or the light blue bar, and this is the supervised exercise. And you can see that the adherence to the mandatory exercise in phase 1 was for the behavioral support was 83%, and for the supervised exercise was 79%, which is actually really high for these kind of interventions. And as in most long-term studies, it decreases, of course, after a while. You can also see the supervised exercise, it wasn't mandatory anymore, so only recommended. And so you can see the decline from 79 to 54 and even 44%. But you can see for the behavioral support sessions, there was also a decline, but the decline was less steep than for the supervised exercise, of course, because they were still mandatory. But so after all, the adherence was quite acceptable. For the primary outcome, the disease-free survival, we can see this graph, which is, of course, very important from statistical point of view. But when we explain it for the clinical relevance, you can see that at the x-axis, every year, they did a calculation of the patients that were still alive, but also the patients that were still in the trial. And so you can see at 60 months, so this means the 5-year disease-free survival, that in the exercise group, 80.3% was still alive. So this is a very high survival rate. And in the other group, in the control group, 73.9% of them were still alive. But this is quite a big difference. And the difference between those two groups, it is significantly different, which means that there is a significant difference between those two groups that we can link, of course, to the intervention. This also means when you calculate the hazard ratio, it means the risk actually of dying from this cancer when not having the intervention is 28% lower. So you have 28% lower risk of recurrence or death in the exercise group. And this is a very high and important number. It's more than 1 out of 4. So these numbers are very spectacular. And when we look at the overall survival, so this is only the patients who died, you can also see this difference of about 7% at 8 years. So they did a longer follow-up here. And if we look at overall survival, we see at 8 years that there is a 37% of risk reduction in the exercise group. This is very high and a very good score. So in the exercise group, 90% was still alive, and in the other group, only 83% was still alive. If we look at these numbers, the magnitude of the benefit of exercise delivered after surgery and the adjuvant chemotherapy, it was almost similar to that of many currently approved standard drug treatments. So if we look, for example, with the exercise, it's the first line, but other types of drugs, like in colon cancer or in non-small cell lung cancer, but also in breast cancer, even triple negative breast cancer, we can see that the absolute overall survival gain for 5 years up to 10 years is also between 5 and 10%, or even worse, only 1.8% at 10 years. So these are very spectacular results that we can achieve the same level of benefit with exercise as with certain drugs. If we look at the secondary outcomes for us as a physiotherapist, of course, very important as well. We look at physical activity and physical fitness. And what we see here is not the difference over time in one group, but the difference between the two groups. And when we look at the moderate to vigorous physical activity between the groups, there is a difference between 5.2 and 4.7 MET hours per week. So the physical activity that those groups were performing was also significantly different from each other. And this is, it was the patients completed it themselves through a questionnaire, which is kind of, or could be seen as a subjective reporting. But we also had the predicted maximum volume of oxygen consumption. And this is really an objective measure of the physical fitness. And as you can see here, the difference between the two groups was also between 1.3 and 2.7 milliliters per body weight per minute. So this is also a big difference between the two groups in favor of the exercise group. Another secondary outcome, which is very important to us as a physiotherapist, is a physical functioning. And here again, we have an objective measure, which is the 6-minute walking test, but also a questionnaire, which is called the short form 36 physical functioning subscore. So it's only a scale, a subscale from this whole questionnaire. But you can see again that there is a big difference between the exercise group and the control group when we look over time. They also had different points where they measured, but so here you can see that it was in the first 3 years, which were very important differences in the length, the walking length from 13 to 13 meters. And for the quality of life questionnaire, as we can call it, it was 1.9 to 5.8. And this is the difference from baseline. So everything below the dotted line is a decrease or a worsening of the quality of life, but everything above the dotted line, it is a progression, so a positive effect on the quality of life. So the higher you are, the better the quality of life. So these are also, again, very positive results. And then we come to the discussion and the conclusion. For the exercise prescription, you can see, but Grainne will also go a little more into depth for this. It was individualized. It was recreational aerobic physical activity. So they didn't take into account, or they didn't calculate the strengthening training in the MET hours. It was moderate to vigorous intensity. Now there are also trials with high intensity training, for example, and the patients could choose the type and the frequency and the duration of their physical activity. They also had the in-person sessions at the beginning, which were very important for the trial, because there they could become familiar with how to use the exercise equipment, also with different types of activity, how moderate and vigorous felt, because that's not a common sense for everyone, how to track the intensity and how to progress. Because of course, over the phases, they had to increase their MET hours per week. When we talk about physical activity and exercise, of course, there can be adverse events, especially with the side effects of cancer along with it. But when we look as a physiotherapist at side effects, we are mostly interested in the musculoskeletal side effects. And you can see that in the exercise program, it was 18.5%, while in the control group, it was 11.5%. But this is something that we could expect, of course, but also for the other side effects, which were if you have higher than a grade 3 adverse effect, it might really affect your quality of life. And so it's really severe. And there we can also see that in the exercise group, those adverse events were higher, so more severe than in the control group. We also talked about the behavioral support sessions, and they were based on, for some people, it might be very abstract what they did in these sessions, but of course, it's to encourage and to support and motivate and coach the patients to change their lifestyle up to a physically active lifestyle. And so it was based on the framework of the theory of planned behavior, which is a psychological model that we use in healthcare. But you can see they used 17 evidence-based techniques for this behavioral change delivered over the 3 phases. And in the column, you can see those 17 topics that they used to support the patients and to try to encourage them and change their behavior over the 3 years. Of course, every clinical trial has some limitations, and the most important ones of this trial is that the recruitment went very slow. They took 15 years to include those 889 patients. And of course, in those 15 years, some things have changed. Like, for example, the schedules for the chemotherapy, they came from 6 months to 3 months. Another point for discussion is the geographical spreading. Like I said, Canada and Australia had more than 83% of the recruitment of the patients, which can also be discussed. And only 92.4% of the patients that they calculated for were randomized, because actually they needed 962 patients and they only randomized those 889 patients. On the other hand, the disease-free survival was higher than expected. They expected 380 events, but in the end, unfortunately, actually, there were only 224 events. So only 58.9% of the events that they actually calculated everything on. So this is a good thing, but for the calculations of the trial, it might be a bias. There was also a selection or recall bias, which means that they included patients that had an ECOG status of 0, which means that they were high-functioning patients, already very active. The timing was also very short. after the diagnosis. It was within the first year after diagnosis that they were included in the trial, while if you take patients longer after the diagnosis, they might be already more deconditioned, for example. And there was also, with the questionnaires that I mentioned, there can be a recall bias because they question the patient retrospectively, and they ask for a self-reporting of their physical fitness. So there might be a recall bias that they do not remember very well everything they did in the past month. And then at last, in the exercise group, of course, they also had more social interaction with the persons that were supporting them, which they didn't have in the control group. But the consortium, they discussed that it's unlikely that it might have affected the survival, but maybe it might have affected, for example, the quality of life, that the exercise group had better results, maybe also due to the effect of social interaction. And then I come to the conclusions. So the first and most important conclusion is that the 3 years structured exercise program after chemo for colon cancer patients significantly increased the moderate to vigorous physical activity. It improved the physical fitness, the patient-reported outcomes, the disease-free survival, and the overall survival, which is what we are talking about, the game changer. The results demonstrate a first-in-class anti-cancer effect. The intervention, the exercise is empowering and achievable for many patients. The magnitude of the disease-free survival and overall survival benefit are similar to standard medical therapies like certain drugs. The challenge trial sets a new standard of care by providing us these results. But knowledge alone will not change the behavior of patients or outcomes. And so the health systems need to invest in physical activity behavior support programs. And that's where Grainne will lead us to the next session. I also have a last slide with a summary for maybe participants that are interested in having a summary to within their institution, maybe also spread the word and be an ambassador for exercise in oncology. So you can find a summary like a knowledge clip on the website of the New England Journal of Medicine, but also an infographic, which I found very instructive. So thank you for listening, and I would be happy to answer any of your questions at the end of the session.
Hi, everyone. So I'm happy to spend the next few minutes just looking back on the paper and trying to think, well, how can we now use this in practice and how can we implement this into practice? And I'll touch on a lot of the detail that Nele has given already, but try maybe to look at it through the lens of changing clinical pathways and how patients can access this type of intervention. And so I guess to start, I was looking at, well, what is the population that were involved? And we've gone through the inclusion and exclusion criteria already. And it's trying to see how generalizable are the results to patients that we might be referred in clinical practice. Patients that are the stage 2 or stage 3 colon cancers. And really the patients that were referred after their treatment had been complete. And there's a lot of discussion at the moment around timing of interventions and when should participants be invited to take part in either research or just clinical programs. I think what this shows us is that even when treatment is complete, there's huge benefits to patients engaging in exercise. And that if patients are given maybe a 2-month window, for example, like in this trial, or longer, to recover from the acute side effects of treatment, they can then be enrolled successfully into these clinical trials. So that's what this happened here. Adjuvant chemotherapy was completed within the last 2 to 6 months. I am going to comment again on the functional status or the performance status of the patients that were involved in the trial. because over 80% of the patients in this study had an ECOG of 0. And that means there were no difficulties with strenuous activity. And that is super that group of participants got such benefit. And we have to think about then how we can enable patients with ECOGs of less than that to participate in these trials. And perhaps, and this is, you know, for all cancer populations, that there is a period of rehabilitation before patients then go on to take part in exercise trials, or that we have access to patients so that we as physiotherapists can adapt the exercise interventions to make them really accessible to all patients. But saying that, the threshold was that patients could be active for 6 minutes. And I think that's really encouraging, that patients had to be able to do that level of activity and then could take part in this intervention. So the health intervention, I'll talk a little bit about first, because always when I read these things, I'm trying to think, well, how much of this is something that I already do, and how much of this is something that I would be able to do? Is there additional training and resources needed to replicate some of the interventions from this study? And as was said, the theoretical model that was followed was around the theory of planned behavior. And so to make a behavior change, in this case, you know, physical activity and exercise, there were 17 key interventions, but they were trying to target these 3 areas. And the first was the patient's attitude towards the behavior. And that was that, did they perceive the exercise intervention to be beneficial? And did they perceive it to be enjoyable? And that's what a lot of the sessions were kind of focused on, discussions between the physical activity counselor and the patient around these topics. And then there was this consideration of, well, patients will resort back to their subjective norm. So what do others do? And what do others think? And how does that affect how likely the patient is to engage in physical activity and exercise? And then the patient or the participants perceived behavioral control. So how easy or difficult did they perceive the exercise intervention to be? And I think we do implement a lot of these conversations in practice as physiotherapists already. And some of the behavioral strategies that are contained in the guidebook, so around highlighting key benefits of physical activity and strategies for how patients might find physical activity more enjoyable and fun, and overcoming barriers, social support, and so on, are things that we incorporate into our exercise programming with patients. And I guess here we can see how important they were in order to kind of make an exercise intervention that patients adhered to, and then continue to adhere to it for 3 years, which we know was the intervention period. So as well as the health intervention, then there's more information given around the exercise intervention. And I think I'll just echo what Nele has said here around how broad the exercise intervention was. So they have stated that the physical activity goal can be achieved by any type of recreational physical activity and any combination in terms of frequency and duration at a moderate to vigorous intensity. And that just makes this very accessible to patients. We are trying to rely on patient preference, and they did use a form for that, and they encouraged the patients to really fit the exercise prescription to something that they would enjoy. A huge proportion of the participants engaged in walking as activity, but then the physical activity counsellor also supported patients to become active within their own communities. So either helped them to find exercise settings that might be suitable for them, particularly in colder months, or to help the participants to find exercise equipment that would be suitable for them. So again, you're just seeing this supportive role come in. The study highlights the importance of the supervised physical activity sessions, and this allowed these physical activity counsellors to explain and observe proper technique, look at things like safety, heart rate monitoring, progression of the exercises, and also served to motivate participants as they were coming in and meeting people face to face. So they did emphasize that supervised component and the benefits of having that in the trial. And again, we're looking at, well, how can we implement that into practice? There was 12 sessions over the first 6 months. Is that something that's feasible in our settings? Or is that something that we need to now look at other models of delivery for? The adherence to the program has been described already, but I just wanted to mention one key component that was incorporated into the program, and that was following up on missed sessions to help to increase adherence. So if patients didn't attend sessions, they were contacted by the physical activity counsellors to follow up and see what had happened and could sessions be rescheduled. And for everyone, the goal was to get those 12 initial sessions in the first 6 months completed in 6 months, even if they were spaced closer together because of missed sessions. And what I think contributed to such adherence, high adherence to the program, was the kind of those first 12 sessions were described in good detail, and there was a goal or learning objectives set for each session. And you can find this in the supplemental material that accompanies the paper. But it just meant that the patients got a really thorough introduction to exercise in those first 6 months. So for example, the very first session was about kind of where they were exercising, how to monitor exercise intensity, how to stretch, and so on, and complete a physical activity log. And then you come down to things like looking at decisional balance, looking at benefits and barriers to exercise, and setting SMART goals. And like I said, they're described really nicely. And there's also kind of what to do. So if the patient meets their physical activity guidelines, how you might progress the patient, but also what to do if the patient didn't achieve their goals. So the final few slides are around, well, how, I guess in the bigger picture, how is this going to be implemented into practice? And I think the length of the intervention is with 3 years. Really, I guess there's a lot of systems, I guess, that don't have that length of interventions in place already. And how can we do that? But patients really adhered very well for the 3 years. So it's showing us if we set it up like from the beginning, the study authors have highlighted that first 6 months appeared to be really key in getting patients to buy in, but also the supplemental material. And again, having seen the results, it states clearly that perhaps the most important aspect of the trial is the relationship between the physical activity consultant and the participant. And that is really important, that therapeutic relationship is built up. And the physical activity consultants are encouraged to ask questions of the patients in terms of their background, what kind of things interest them, and to build up that rapport. And then we have to look at, well, the model for 3 years was designed, 15 years ago, and things have changed a lot since then. We now have accessibility, greater accessibility to online programs. Perhaps hybrid approaches would work and could assist kind of patients who are in more rural settings with poorer access to take part in some of the trials. And also in the longer term, that those hybrid models or engaging in online programs might help. So there's no answers to these questions, but I think this might help us to kind of work towards an answer. So the first is, well, how acceptable is this treatment for patients? There was slow recruitment. Patients had already had a year of treatment, so they'd already had surgery and adjuvant chemotherapy, and then were asked to take part in an exercise program. And perhaps that's we have to see the recruitment rate of about 60 a year, trying to see would it be similar proportions of patients wanting to take part in practice, or could you have less or more perhaps with changing the design of the support that's given? Again, if we design these programs, do we restrict it to colon cancer, which was the population in this study? But also there are populations such as rectal cancer or breast cancer, where you might see observational data with similar findings, but no phase 3 trials completed. Can we use these results to expand these programs to other cancer types? The optimal place or mode of delivery might need further investigation, and also the timing of delivery. funding models, and again, there's some discussion around this online, and from presentations, the authors have kind of discussed how many sessions were provided over the 3 years. So 48 sessions were provided over 3 years, and they give a conservative estimate of the cost per hour of being $60 to $100. We're looking at small costs in the grand scheme of things in terms of supplying or providing a 3-year program for patients. Compared to drug costs, the cost is minuscule. So we're trying to put this in the context of the much larger outlay in terms of drugs, again, as has been described with similar results, and how this can be implemented on a much smaller budget. How would that be run? And again, Chris Booth has presented as an author of the study on this, and this is very much some of the suggestions that were made. So you could have a decentralized delivery model where the funding follows the patient. So either the patient has the funding and is given, they seek the exercise intervention themselves somewhere closer to them, or they pay and claim back for the program. Or you could provide this in cancer centres. So that's integrated into the care of the patient, and the cancer centre provides the physical activity counsellor. You could partner with existing models. One example given is a cardiac rehab program, but it could be respiratory programs and so on to take these patients on board. Or you could have a community-based delivery model where existing programs now include cancer patients, or cancer exercise specialists are integrated into the community to deliver these type of programs. The main findings or messages, again, are around exercise, and that it's really, this piece is around outcomes and not a kind of a quality of life or well-being. We can talk in much kind of bit larger terms than that now. But the support and guidance appear to be key. So providing someone that will guide patients through this intervention really seems to be why this was so effective. And access to this type of person or supervision or guidance needs to be included in standard care pathways. But ultimately, it's up to people to advocate for these services and to advocate for change as to what is the current standard of care, which is so vastly different depending on where the patient receives their treatment. And it shouldn't be. We should be able to now say that there's a minimal kind of standard or minimal support that patients should get in order to incorporate exercise into their care pathway.
Do you think the fact that they were so slow to recruit, they started almost 17 years ago, I think it was 70. Do you think nowadays, with the changes that occurred in all that time, would you think that it would be easier? Because I think in getting patients into our service isn't that hard, right? People are more aware, and people are the patients, and people are actually looking out for different programs. So do you think that recruitment part is due to awareness of physical activity when they began, or was there another issue?
Maybe I'll start, and Nele can come in as well. But I think it's tricky with research, right? Because the people approached for this trial would have known they'd be randomized. So potentially they wouldn't get access to an exercise intervention. And perhaps that, when we see patients attending our services with such interest, it's kind of different because they have to be approached and told, well, half the group won't get the exercise. And then the other thing is, I guess it's a 3-year intervention. And did that put some people off enrolling in the trial? You would like to think that in practice, the numbers for this, would be much larger. There's, I think, half a million people in Europe diagnosed with colon cancer every year. So you're trying to think the numbers are quite big. It's just, how is this delivered in practice? I think you could get more patients interested. There will always be that piece around appealing to people who don't perceive exercise as beneficial. That's a separate question, but that I don't think that's gone away for everyone, but I certainly think the appetite is larger than it would have been when the trial was proposed all that time ago.
Thanks. Nele?
Yes, I also think not specifically for the trial, but in clinical practice, unfortunately, the incidences of cancer patients in general is just increasing over the years. And so by 2030, and that's why we have the Europe's Beating Cancer Plan, the incidence will even rise and keep on rising. So in the future, if they are planning more of those clinical studies, there will be more patients. But I also think that there is a difference between countries in Europe and throughout the world. In Belgium, for example, where I live, the patient doesn't have direct access to the physiotherapist. So they need to have a referral from a medical doctor. It can be a general practitioner, but also a hematologist or an oncologist, a specialist. And so there is also a kind of a burden that they need to have this in-between step. They cannot enter the program directly. They need to be referred. And that's a problem that we are facing currently in Belgium, that we only have like 10% of the referrals. And from these 10%, as Grainne said, not all the patients are interested in participating. But that's why I think, and that's also one of the key messages, that this behavioral support and the behavioral change sessions are also very important. Actually, they should precede the exercise. From the moment of diagnosis, or the sooner the better, we should inform the patients about the importance of exercise and try to change their lifestyle to a more healthy and physically active lifestyle. And so from the moment that they are ready to do exercise, they could start as fast as possible. And then they already have this mind shift why they are doing this and why they have to stay physically active for the rest of their lives, even if they are the hardest one to yeah to convince to start off with kind of those kind of problems. And I don't think the colon cancer population is the hardest one. Without putting stigma or anything, I think in Belgium the lung cancer population is even a harder population to convince to start exercise trials.
Thanks. There are some questions coming in, and in a minute, Miguel will be able to allow people to come in and ask the questions. It might be easier. I have a question which I think it's one of the major ones arising. I think we probably all of us agree that it's and we cannot expect to have the patient coming to physiotherapy for 3 years or follow him up intensely. Where do you think is the more crucial role of physiotherapists, and when can we allow the patient or enable the patient or empower the patient to go and do their own thing in the gym or with an instructor or whatever? Where should we emphasize, and why the role of the physiotherapist?
You want
Nele?
to go me first?
Yeah.
I think there are already some interesting models that were published on this topic by, for example, Martijn Stuyven from the Netherlands, but also Nicole Stout. And so they made like a model on the complexity of the medical indication. So from the moment that there is still a complex medical condition, you need to have a multidisciplinary team for supervised rehabilitation. You
For
wanted
anyone
to...
looking for it, it's called a stratified model, and you can find it.
Yes.
Yeah.
Yeah, so I think they have a very good idea about, depending on the medical condition, but also, for example, the self-efficacy of the patient. If the patients are able to do it on their own and there are no more medical complex cases, then of course we from the hospital, we also want them to integrate into regular physical activity or regular sports clubs. So I think we already know this. There are criteria and models to decide on this.
Ronnie?
Yeah, I think we need to see the most complex presentations or the patients with maybe the most kind of burdensome symptoms, because that's where our skill set lie, and the numbers of patients are so vast that we need to kind of look at those models and leave patients that have, that are able to manage with group programs, supervised programs, community-based programs to do that. And hopefully over time, the patients we see will be able to integrate into those programs as well. But I think the patients with the most kind of highest burden of side effects of treatment and symptoms would benefit from seeing us the most. And that's where we can kind of make the most impact.
There was a question coming in from Alessandro to Grainne. Could you please go through the price per patient subject again? Because that might be a crucial point to translate this study into practice.
And I think one thing I'll say here is that there are going to be many papers from this study, and this is the first, but there will be a full analysis of the health economics of the paper. An implementation plan will come, and I think they have biological samples as well. The rough estimates, and again, this was one of the study authors, Chris Booth, had said, well, if you think about the 48 sessions that were included in the program, and you try and put a cost on each of those sessions, they arrived at an estimate of $3,000 to $4,000. It really depends on where you are and how much that hour would cost. They costed it at, say, for example, $60, you're at $3,000 and then potentially more. But that's a really broad figure. So I guess we're trying to take away from that the cost of those for providing those sessions over the 3 years.
Thanks. And then there was another question, and that could Nele or Grainne. How do you balance patients with existing comorbidities and in a care pathway such as COPD or cardiovascular, like it is in real life practice? How do you make it work? Nele, do you want to answer? We'll give Grainne a rest.
Yes, most of the patients, they have adverse events and they have plenty. And so I think you should make, together with your patient, you should discuss the question from the patient, which is the most harmful adverse event, and then tackle this one first. Because some of them, we always have a multifactorial case. And so I think it's, a clinical decision making, but also a shared decision making with your patient, how you want to prioritize those things. And sometimes you cannot do it with only exercise. The exercise programs or physical activity in general is only a small part of the role of the physiotherapist within the cancer journey. And that's what Michele also presented at the very beginning, our publication from 2023. It's really our role from diagnosis and even in prevention up until the late stages, the end of life care. And in each of those stages, we have a role as a physiotherapist. And so it's not only exercise, it's also the motivation, for example, the education, but also symptom control. And so if pain is the major adverse event, then you should tackle the pain first or simultaneously. So I think you need to look at this case by case and discuss with your patient.
You've already answered another question about prehab. If it's a standardized part of the pathway, it is in our position paper, and you can find the position paper. Miguel put up the link, or you can go to the European Region of World Physiotherapy site, and the cancer group document is there as well with other documents. And certainly we should start immediately after diagnosis with the patient. And it could be sometimes it could probably be just a consultation and education maybe, and throughout the phase. And again, we need to put that in the time context that this study started quite a few years ago. So it looked at the survivorship term after the medical intervention. We have quite a lot of research showing that rehabilitation is effective, and very quick, immediate intervention within the medical treatment is also very effective. There was so we answered the rehabilitation part, and there is another question about if there was specific any exercise showed higher effect. That wasn't actually looked at. There are other studies, and about resistance exercises, and I'll answer that if I may, because resistance thing is I think it's very promising, the effect of resistance exercise. But it's not looked at in this study, and it's promising also because it probably takes less. We can have often the same effect with less time, and these patients, the cancer patients specifically, are really burdened with all the tests and then the intervention and then the medical. We need to make everything more easier for them to do. And there was a new question: was ethnicity accounted for in the recruitment of participants and evaluation of the study, as culture plays part of behavioral change? Nele, would you like to answer that?
I'm not aware of any sub-analysis on the culture. Maybe if we have a look at the demographic characteristics, but I'm not sure that it's in there. We only know that the majority of the patients were recruited in Canada and Australia. So that's already, I think, a cultural difference from the other studies that were also recruiting, the other centers that were also recruiting patients. But I'm not sure if they did any, because of course culture is also a very broad sense. So I'm not sure what is it about ethnicity or is it really about culture. But I'm not aware of any sub-analysis on this.
Thanks.
But
So
it's a good point.
So I'll ask, and so where do we go now? Where do we go from here? Now that we have evidence that a treatment and intervention we provide is on the same level of effect and even more like any other medical intervention specific group of patients get. It affects their life. It affects the mortality. It affects survivorship. It is very, very strong effect when you look at the other stuff. So where do we go from here? Nele?
We called it a game changer, the title of this webinar. So I think things need to change and it will not be easy. But that's why I'm very proud to be in this team in Europe. And I see that there are many participants from outside of Europe as well. But if we can start like the paper from the beginning of this month with making changes at the policy level in Europe, I think we are already making baby steps, but it's better than no steps. So I think, things need to change. We need to be out there. We are already ambassadors, and I hope that the participants also felt it and will also be an ambassador for exercise oncology in their country, so that we can spread the word, and throughout the world.
Thanks. Thank you. Grainne?
Yeah, I agree. I think we have to advocate for our role in enabling patients to be active. And I think we need to start initiating conversations with the people that we work with or people that we don't work with, but maybe we should work with, and start to talk about these type of programs with them. I think sometimes there's drug trials publish in a certain way and have certain results, and they talk about the data a certain way, and this trial will allow us to really do that now, because it's powered on on disease-free survival. I think it's a very convincing argument, but it may be a conversation starter, and that's how it can be used to open wider discussions about how patients should be able to access this care.
I think we should actually cooperate, and we are starting to do that, and it is being effective with the people who are really affected by that disease and our intervention, and reach out to patient groups. There are some of them are very effective in advocacy. They know how to fight for the rights, and are involved in regulation and policy. And for them, so far they see it as a game changer as well, and they would like this physical activity to be more accessible and provided to as many patients as we can. So I think a good strategy would be to reach out to the patient groups and start working with them. A lot of them also have all kind of physical activity initiatives within the group, so that we can work through that. So I think it's agreed that it is a game changer, right? It is a moment in the history of physiotherapy for cancer care, because we are not an adjunct anymore, nice to have quality of life. It does affect survivorship, and in a very impressive matter. And if, like any other reasonably priced drugs, medication, which most cancer medication are not, they are very expensive. Each patient should be offered it and should have access to it. And I think our responsibility is to advocate, but also to provide a very extensive and quality care. We have two more questions. One, do you think that it would make a difference to educate generalists and oncologists about our role? Grainne, you agree?
Yeah. Yeah.
Yeah.
Absolutely. Yeah. I think it's just still under valued, the role of physiotherapy in cancer care, and maybe just the awareness isn't there yet, but that's our job to kind of increase awareness of our role within this group.
Thanks. And there is from Malta, just letting us know that they already offer physio-guided exercise classes for cancer survivors in an oncology center, and they've been going on it for 9 years. Yeah, it has been. We need to upscale and keep upscaling, and I think Ronnie had some good ideas how we can do that. I think Ronnie, your research was some of your research was on telerehabilitation or telemedicine.
Yeah, we've used that as an intervention with patients. Yeah. But I think it's no one thing will suit everybody. And it's the physiotherapist being able to provide individualized programs that will be key. I think we'll have to use lots of different strategies, and telehealth should absolutely be one of those. Yeah.
And yeah, we are just in our center. We're starting and funny how it came about. We're starting a dance therapy group because we had a pilot. Patients loved it, and a lot of people are coming. So you can just look around and give a lot of opportunity. So adherence will keep being high. Actually, adherence in cancer with cancer and physical activity, I think, is generally high. In rehabilitation, it's very high. I mean, in rehabilitation studies, adherence is very high. So I think we are reaching out. We are successful in getting the patients involved, those who actually get to physical therapy. You agree, Grainne?
Yeah, I think so. I think broadly we are. I think there's some groups, and again, it depends on your center who are the best referrers, and trying to make that even. If you have certain teams that are brilliant at referring, that's super. But what about other teams? And what about groups that we know will, particularly benefit those on, neoadjuvant treatment, or in this instance, it might allow us to kind of build up relationships with the colorectal teams. So I think broadly, yeah, but I think there's always more work to be done.
Thanks. Nele, do you want to add anything before we go? We say bye-bye, good night.
No, I can only agree. It's the same situation in Belgium. I think we need to convince them, and this is one of the publications that we really need to put in front of their nose and explain it to them why this is so important. And maybe there are still some barriers from their side that we also need to know, so that we can act or react to it. And so apart from the barriers that live with the patients, I also think that there are some barriers from the side of the oncologist or the general practitioners.
Michele, do you have
No,
you're going to sing an alibi for us?
no, it's all good. I want to thank you all for this beautiful night together. I think that was very worth it to be here. Also, I have a exercise book full of notes from this night because the contents of the challenge trial is really high, and I hope that people from here they will start to study themselves, speaks together as physiotherapists, talks to people, people talks to people talks to their general practitioner, and this is how the communication starts, to make everybody aware of them, and then reaching out to stakeholders are essential for the strategy to go to the systems and change it by inside, with stakeholders like patients organizations. We go direct to the policymakers and we can do the change. We have to do this, but we have to start talking in our communities together, among professionals, with citizens, with people, and then go to the great organization to go higher in the level of the system. And it's up to us, not only to the region, not only to the big names in Europe, but it's a game changing that everybody tonight here should start to do by tomorrow at work. So I hope this will start something together. Thank you so much.